so I'm going to focus on the issues of establishing the preconditions for relaxing the statewide shutdown, namely having the capacity to rapidly test suspected cases, trace their close contacts, and quarantine them to stem the growth of the epidemic. In addition, we must have data to inform triggers for reimposing lockdown should the epidemic surge. Let me start speaking as a modeler to address the consequences of the measures currently in place, namely the travel restrictions, the stay-at-home order, and the social distancing requirements. For the most part, I do believe that they have had the desired effect. We are still seeing comparatively slow growth of hospitalizations and deaths, remaining well within our health system's capacity. Because this virus usually manifests with symptoms in less than 2 weeks, if the virus were widespread in the community, these numbers would be growing more rapidly. The worry I do have is that because these social isolation measures have been so effective, only a small fraction of the population has contracted the COVID-19 virus so far. Based on experiences with other coronaviruses, these people are likely to have some measure of at least temporary immunity to reinfection. However, the rest of the population, the other 99.9% of us, are still as vulnerable to infection as ever. This virus spreads remarkably easily and quickly. In the absence of controls, each person infected transmits the virus to 2 or 3 others, usually within a period of several days, and sometimes before they even develop symptoms. If we were to lift the shutdown measures now and go back to our previous way of life, we could easily find ourselves in a New York-type situation within a month or 2. The growing cluster of Maui Memorial illustrates the potential of a handful of infections spreading rapidly in an island setting. Singapore, which has aggressively tracked this epidemic, has seen clusters of infection around workplaces, gyms, preschools, shipyards, private functions, churches, and dormitories. It spreads easily and rapidly if people aren't taking precautions. Thus, as we lift the restrictions, unless we are prepared to see this epidemic take off again, we will need to identify new infections promptly, trace their close contacts, and get those people into isolation as quickly as we can. This creates preconditions for lifting the shutdown. We must have a solid testing and contact tracing program in place, and we must have the ability to ensure isolation of close contacts of coronavirus cases from the community. If we reopen without these programs in place, we're wearing blinders and piloting a leaky boat as we fight a deadly virus. If we are to effectively reduce the likelihood of increased community spread as restrictions loosen, we must be operating from a clear, real-time picture of what the virus is doing. This will give us the ability to reimpose restrictions if needed to arrest community spread. Some have described these as circuit breakers. This requires that our systems allow action to be taken on the timescales of the virus. The average incubation period of this virus is between 5 and 14 days. There is evidence of the virus being transmitted a day or 2 before symptoms occur. In addition, there is normally a delay between the onset of symptoms and treatment seeking or hospitalization, which is when a person normally receives a test. If we add to this a several-day delay in getting test results, we have given the virus ample time to spread, and our picture of the epidemic is badly out of date. If we're going to get ahead of the virus, our testing system needs to have the following features. First, rapid turnaround. We should be moving to point-of-care rapid test or quick turnaround lab test, returning results within 24 hours. We recognize that this will be gated by testing system and kit availability, but it is a goal we must strive for. Local testing. The system must shift from a dependence on mainland test labs that have multi-day turnarounds. These reduce our ability to separate a surge in coronavirus from an outbreak of flu or another respiratory illness. Additional local laboratory capacity should be identified or developed. We need ample capacity to support multiple needs. These needs include diagnosis, testing of close contacts, testing of healthcare workers, and other symptomatic frontline workers at businesses, and support of extensive surveillance of all cases matching a coronavirus case definition. And finally, in testing, we need metrics. In my experience, systems do not improve unless there are clear metrics for performance. A system of metrics should be designed and made available in a publicly accessible dashboard. Some such metrics might include average time from sample collection to reporting of a test result for contact tracing, average time for a diagnostic test to return a result to the physician, or percent of tests done locally in Hawaii. I'm sure others can come up with additional metrics that would be of use. It should be noted that we are not talking about a temporary surge in lab capacity here. We will need sustained capacity. This virus will probably be with us until a vaccine is developed, that is, for 1 or 2 years. and we must have the ability to monitor it carefully throughout that entire time frame. Testing without action accomplishes nothing. Every test should be tied to an action, whether to improve healthcare for the individual, to identify those individuals whose close contacts must be urgently reached, or to provide the public a clearer picture of the epidemic in Hawaii. Our contact tracing system needs to be strengthened significantly to ensure, first, rapid interviews. Every diagnosed patient or detected infection must be interviewed for contact tracing promptly. Again, we should move toward a 24-hour standard for this. Adequate staffing to reach all close contacts. Enough staff are needed to conduct the initial interviews, reach close contacts for quarantine, ask other potential contacts to self-monitor for symptoms, and follow up on the quarantines and self-monitoring. This capacity must exist across all islands. Next, we need transparency and openness with the public. Contact tracing serves not only to identify additional cases, but it also provides information about clusters of infection. The public needs to be aware of these clusters so they can better understand transmission in the community and take steps to protect themselves. Recent mention of clusters around families, church groups, and biker games need to be made public knowledge, not by naming the specific groups or locations, but by letting public know the types of settings where the virus is spreading so that they can take the steps necessary to protect themselves. And as with testing, we need metrics for contact tracing. There should be metrics available in a public dashboard that might include receipt of diagnostic test results and interview, the number of days between those two, the average number of close contacts per person, or the average close contacts reached per contact tracer. The staffing needs here should not be underestimated. In Singapore, the first 108 cases identified over 3,000 close contacts. That's 29 per person. Keeling and his colleagues in the UK using social survey data estimated there might be 36 close contacts per person using a 2-meter, 15-minute definition. That is, somebody was within 2 meters of somebody who was a coronavirus case for 15 minutes or longer. It will be valuable to examine the Hawaii contact tracing data to estimate the average number of contacts and use this in combination with a time to trace standard to identify our staffing needs and expand staff accordingly. Electronic technologies can serve two key support roles in this contact tracing and isolation. First, they can help to monitor and enforce quarantine requirements. Second, they can be used to allow easier identification of close contacts for contact tracing purposes. Several systems like this are under development, including one from Google and Apple, the Trace Together app, which is used in Singapore, and the Safe Paths app, which is coming out of MIT. These systems are all striving to protect privacy concerns while making it easier to reach close contacts promptly. One additional precondition for lifting restrictions is that strong ongoing prevention for COVID-19 must be in place and widely accepted by the public. This includes the availability of personal protective equipment. We need enough to cover all healthcare workers and other frontline workers in Hawaii. Once we have adequate supplies for these essential workers, we then need to ensure that adequate surgical masks are also available for the public as soon as possible. These are far more effective than the cloth masks recommended now and should become the standard in all public settings once the demand for supply can be met. We need public buy-in to the need for continued social distancing. Some people are already starting to chafe under the stay-at-home order. So we need a major publicity campaign to explain to the public why social distancing, use of masks, and avoiding crowds need to remain the norm after the stay-at-home order is lifted. The trust of the public will be best built by enlisting them as an essential component of the response, not by heavy-handed enforcement of policies they do not understand. Transparency and openness about ongoing infections and observed clusters of infections can also help to build the public's willingness to continue these practices. We clearly need to pay special attention in Hawaii to our kapuna and those with elevated risk. Given our multi-generational family structures here, we must ensure that people understand the need to protect their family and friends who are at risk. It's not enough that those at risk stay isolated, but other family members must take steps to avoid transmission in households. Extending stay at or work at home opportunities for those at risk or their family members could make a major contribution toward achieving this. And finally, when we reopen, workplaces and businesses need to ensure social distancing. This requirement is not going to go away for the next year or two. Finally, they need to make it easier for employees and customers to maintain their social distance. This may involve reducing the number of clients physically reorganizing workspaces or customer spaces, or making hand sanitizer readily available on site. Hawaii's geographic isolation and its willingness to act early against COVID-19 have given us a unique opportunity to make test, trace, and isolate work. But to be successful, we must be proactive, not reactive. We must move on the timeframes of the virus, not the timeframes of a bureaucracy. If we put these systems in place, we can easily satisfy the additional requirements for reopening of declining cases and adequate hospital capacity. However, if we don't move with a sense of extreme urgency to strengthen our testing and contact tracing systems, the virus will get ahead of us and we won't be able to catch up. Thank you.
I'd like to say a few words about the testing when the time comes. I would agree with everything Dr. Brown has been laid out as what needs to be done, but I think there's an undue focus on this whole testing issue. Testing doesn't change anything that we do. Honestly, the social distancing is what prevents the disease in our state. The testing that we're doing now, at least, has been done largely for diagnostic purposes and as a way of confirming a person has COVID-19. But the decisions made on quarantine and isolation are made long before we get a test result. It, again, is helpful in confirming the person has the disease, but it doesn't change how we deal with the issue. I don't argue that we don't need more capacity, and having quick turnaround is helpful even for diagnostic purposes. Our current capacity at our private labs is probably less than a couple of hundred tests per day, and with this drive-through screening, it results in a lot of samples being sent to the mainland for analysis. So when you talk about pooling samples and testing, you're just testing people for antibody and really determining the prevalence of the disease in an area, similar to what we do with our Sentinel surveillance program, which I think has a huge role to play going forward. But the ability to test quickly is important for the diagnostic purposes, but it doesn't help you in understanding who is potentially infected. It's a point in time test. It is effective if someone's symptomatic in identifying what they have and what course of treatment might be appropriate for the individual, but it certainly doesn't help you in making decisions on social distancing and other things that need to be done. So I don't discount the value of having a rapid test. It's very helpful. Certainly waiting days to get a result back from the mainland is unacceptable. But this whole idea that we do this mass testing is, I think, not, with the test we have approved today, is not appropriate. When we do get the antibody test in place, where we can tell whether someone's been infected in the past, then I think we'll have a much better handle on the extent of the disease in Hawaii, and then that will help shape our policies. But right now, I just want to emphasize that this contact tracing, identifying cases, contact tracing is really where the action is. That's what's effective in most places which have been successful in keeping the curve down, including Hawaii. As the gentleman mentioned, we have 5 cases today. We've had, I think, 13 yesterday. It's not an unmanageable situation, largely because we are on every case and aggressively pursuing the contacts. We do have a need for more staff to be doing that, and in the future, I think that's going to be a major component of our program. 30, 40 contacts is not unusual for every case. And obviously, if we have, a dozen or so cases, we can handle that. But if we get up to the point of having 100 cases, it's a whole different story. Or if we have a large cluster like we had in Maui, we're stressed to be able to follow up appropriately. But I just wanted to emphasize the point that the current test is just looking for antigen in the individual. It looks at whether the person is actively infected with the virus, and that's all it does. A day later, that person can go outside and be exposed and then transmit the disease. Often, I'm concerned it's giving people a false sense of security that they've been tested, but all it's really doing is telling you when you got the test, whether you are actively carrying the virus. In fact, it doesn't even do that because it takes days for the virus to build up in your system to the point where you detect it with the current test. So I think new tests are needed. The antibody test is going to be very helpful to us for public health purposes. But that's not, in my mind, that's not the constraint that we have right now. Our focus really should be and continues to be a focus on identifying cases and contact tracing. That's where we put people in isolation or quarantine if they're likely to transmit the disease. And so far, that's been very effective in keeping the curve down here in Hawaii. So I just throw that out there for consideration. Again, all the other points that, of course, General Har and Dr. Brown have made are well taken. And I'm not discounting the value of having tests available to us, but we do need to understand the limitations of those and not think that just because we have a test available, we have the problem solved. It's a tool, but it's not going to be the solution to controlling the disease here. That's going to come back to contact tracing, surveillance using antibody tests and other means, and just continual vigilance on the social distancing issues. That's all I wanted to add.